All right. So thanks everybody for jumping on real quickly. We've got a really interesting guest and to share a lot of information with us today, and very grateful that Dr. Jeff Teuteberg is taking the time to speak with us. Just briefly, I'd like to introduce Dr. Teuteberg to the group. He's currently the Section Chief of Heart Failure, Cardiac Transplantation, and Mechanical Circulatory Support at Stanford. He sees patients both in the clinic and the hospital with advanced heart failure, those that have received cardiac transplant or MCS, LVAD, durable LVAD in the past. Dr. Teuteberg's research interests are in clinical outcomes in patients after transplant and mechanical circulatory support, as well as novel approaches to immunosuppression. He has participated in many single-center and multi-institutional research studies, has published widely in the fields of transplant and mechanical support, and served as the president of the International Society of Heart and Lung Transplantation in 2018. A person that has a lot of experience and wisdom to share with us today, that I'm sure. Dr. Teuteberg, thank you again for joining us, and please, the floor is yours.
Thanks. Let me try and share my screen, see if you guys. Do you guys see like the full screen thing, or are you seeing my presenter view?
It's still taking time. I think right now we just have a black screen still.
Let me try doing something real quick. You got up to 2 years and this wouldn't be a problem. Let's see. Why won't this?
We have plenty of time, so just take your time.
Show. There we go. That should work. Let's see if I can get it. How's that? Is it showing on your guys' side?
Yeah, I'm waiting. Yes, now it is. Perfect.
All right.
Just there's a little bit of a time delay from the West Coast to the East Coast, I think.
So again, I appreciate you guys inviting me to talk with you today. I do have some conflicts of interest to disclose, many of which revolve around mechanical circulatory support. But now that we're down to one device, I guess I'm sort of universally conflicted with some of the information. But again, I think that a lot of this stuff is relatively new and not specific to any one particular device, and is more specific to the field. So I thought I'd start with kind of a handful of sort of introductory slides to kind of give the sense of the background upon which this paper is based. You know, I think everybody recognizes that this used to be a slide with a few devices on it, and now it's just down to one device, the HeartMate 3. And you know, there's clearly a lot of advantages to the newer generations of device, or I should say the newer generation of device, in terms of outcomes and adverse events and the like. But you know, in the end, the LVAD is still really dependent on adequate RV function. And I think it's one of the things that we still struggle with, despite all the improvements in technology, because those improvements in technology don't necessarily impact on the right ventricle. And I think we've known for a long time that there's impacts on the right ventricle from throughout the sort of whole course of patients on LVADs. This is the first big series of patients with continuous flow devices that Bob Cormos and I published along with others, looking at HeartMate 2s. And not surprisingly, this has kind of probably been replicated in almost every device that's out there. The patients with right heart failure tend to do worse than the patients with no right heart failure. Or when you sort of look at Intermax, I'll sort of draw the lines over those, you know, it's what we see in the early trials is what we continue to see both with continuous flow devices as an isolated LVAD and frankly with continuous flow devices when tried to be implemented as biventricular devices as well. So this is sort of hot off the presses in terms of new data, but this is what the most recent Intermax report looks like, and it looks a lot like the one we published a couple of years ago in terms of the percentage of devices. And why this sort of really matters is we sort of evolve from a sort of half DT, half BTT implantation to now almost 80% DT, is that the implications for right heart failure. So if patients don't do well and their RV is not doing great, then they may be stuck with RV failure for long periods of time. So I think it's become even more important that we sort of figure out what's going on with the right ventricle. And it's not just mortality, and it's not just some of the quality of life issues. It's all the other things that sort of go along with it that make patients not do as well and stay in the hospital for a long time. They get stuck with gut edema and they don't absorb their medicines, and their nutrition's not so good, and it impacts their exercise capacity in addition to the LVAD itself. So if you kind of say, okay, well, what do we mean by right ventricular failure? Traditionally, it's been described as the need for an RVAD or prolonged inotropes. And even the definition of quote unquote prolonged inotropes is a little bit variable. It's anywhere from 7 to maybe 14 days postoperatively. Although for the folks that are in the field, they recognize that sometimes patients are on inotropes for that long for other reasons, or maybe that if you turn it off at day 9 and you're looking at 10 days for RV failure, is that really a big deal? Or if you keep it on to day 11 and you count 10 days as RV failure, does that really make the person do that much worse? So it's not really based upon any solid definition, but it's sort of the definition that we've been stuck with for a long time. But we also know it's kind of when you get beyond the first, couple of weeks post-implant, that there's still an impact of RV failure when you sort of look at this data from Intermax from a number of years ago, but the data still looks the same. If you look at right heart failure in green, the sort of risk is highest early, not surprisingly, just given the patient's condition and the perioperative period, but it still kind of lingers on thereafter. And so when we sort of thought about sort of ways to predict right ventricular dysfunction, there's been lots of models, and the reason we have lots of models is none of them are all that good for a variety of different reasons, including pump types and what they look at and how you define RV failure and a lot of other things. And I think that, we still look at the right ventricle and try and make some decisions based upon the way the echo looks or way CT scans look. And, looks can be deceiving. And I'm not a big believer in sort of the way the RV looks on an echocardiogram, although I think a lot of people sort of default to that. I think you need things that are a little bit more specific rather than just kind of the eyeball test. And, some of those things have been developed over time with echocardiography. But again, I don't think any one is necessarily better than the other. And it's usually sort of a combination of factors, and typically is a combination of factors plus kind of local expertise. And ultimately, hemodynamics are the best things, and I won't go into the gory details about all the sort of right heart hemodynamics, but there's also a lot of things you can look at. And again, not one thing is the thing. I think the more things that sort of point in the direction of RV failure, the higher the risk. But it's still not a perfect predictor of what's going to happen. And when you sort of look at more complex relationships from Intermax about all these different things with one another, again, I think that some of the predictors may be a little bit stronger than the others, but I don't think there's one in particular that I use that I find is like the ultimate predictor. It's kind of that combined with some echo parameters combined with kind of what the risk is for the patient. I think people have looked at things like strain, and this is data from my colleague from back in Pittsburgh and now is out here in San Francisco, UCSF, Mark Simon. And I think these sorts of measurements in terms of looking at sort of novel assessments of the right ventricle will be important over time. But again, I still think it's still, a lot of this sort of prediction is still in its infancy. And one of the other kind of major limitations of sort of thinking about right ventricular dysfunction is that all these risk scores, you have some characteristic that you look at, whether it's the patient or whether it's the hemodynamics or whether it's the echocardiogram or all of those things. And then you look at some outcome, which is an RVAD or early or later inotropes, and then you kind of figure out what your predictors are. But there's so much that happens in the operating room that can really impact what happens with the right ventricle. You can take someone who has a pretty normal right ventricle and otherwise a pretty low predicted risk of right ventricular dysfunction. And if you get into something that bleeds, you get a lot of blood products and you kind of flood their lungs and you get trolley, then all of a sudden that puts a lot of stress on the right ventricle and you end up with right ventricular failure. On the flip side of that, if you take somebody with a very marginal right ventricle by whatever criteria you want to use, and you can get the person through the operation without a lot of bleeding and without a lot of muss or fuss, and that person may actually do fairly well. So most of these things don't take those intraoperative effects into account. That earlier study that I showed you with HeartMate 2s that was kind of the first kind of big continuous flow look at right ventricular dysfunction did actually look at the operating room, because I think one of the things that Bob was pushing for as we were putting this together was, what happens in the operating room, and is there a way to quantify that? And we see that the patients who have longer OR times, particularly patients who have longer OR times and lots of bleeding, tend to have right ventricular dysfunction. So I think what happens in the OR matters, and I think it's something that these predictive things don't really take into account. And I think that there's also sort of a growing thought that, maybe we can just treat it afterwards and it's not that big of a deal. And I'm not so sure we're great at that either. I think people sort of tend to go to things like sildenafil, and this is a large study looking at patients from Intermax who are on sildenafil and looking at survival over time. And actually patients who are on sildenafil tend to do worse and tend to have more right heart failure. Now, is that an impact of sildenafil itself? Is that an impact for the patients who are higher risk? And so those are the patients you're treating with sildenafil, so they have worse outcomes. I tend to favor probably the latter rather than the former, but it shows you just because these things are available, I'm not sure they're super effective in their impact on the person's right ventricle over time. So that was kind of the basis of thinking about the paper that I'm about to present. And so the other thing that I think everybody recognizes is the degree of RV failure matters. As I showed you a couple of slides ago, if you just do it as RV failure equals an RVAD or equals inotropes for 14 days post-op, it's kind of relatively limiting. But when you kind of look at larger patient populations, in this case in Intermax, and look at sort of, okay, what is the definition of RV failure? What is the duration of inotropes? Is it less than 7 days, which I think we'd all agree pretty much everybody's on some sort of inotrope for the first week post-operatively, or is it some gradation up to 3 weeks, or is it an RVAD? You can see the longer you need support or the more aggressive support in the case of an RVAD, the worse you do over time. And it's not just sort of time to death. When you look at time to death, heart failure, and things like GI bleeds, you can see the same thing. The patients that require longer durations of support or higher degrees of support, in the case of the RVAD, tend to do worse over time. And then that kind of gets us into thinking about, well, if there's not only kind of different degrees of right heart failure, there's a sort of different time frame of right heart failure as well. And this is Jonathan Rich, the first kind of big publication with continuous flow devices looking at the sort of phenomenon of late right heart failure. So what constitutes late? I don't know that we all necessarily agree. But in this case, if you look at patients who were quantifying right heart failure after their discharge from their implant hospitalization, the people who developed late heart failure not only didn't do as well in terms of survival, but things like quality of life were worse as well. So as all this data was kind of being put together a number of years ago, Intermax said, well, we recognize that the definition of RV failure is inadequate. So RVAD plus inotropes for 14 days isn't really great. So in an effort to try to sort of clarify some of these issues in terms of the degree of right heart failure and the timing of right heart failure, we developed a definition that I think is probably in retrospect too complex, but tried to kind of get at these things. So right heart failure required some sort of elevation of CVP or manifestations of that elevated CVP, and I'll show you what that looks like in a second. And then it talked a little bit about severity as well of the right heart failure. And then it also allowed you to look periodically, do you meet these criteria for RV failure over time? So as it followed at 3 months, 6 months, 12 months, and then every 6 months thereafter. So again, we're trying to get at the degree of right heart failure and then the timing of right heart failure over time. So that kind of formed the basis of this study. So once we made that change in Intermax, we went back after a number of years to say, okay, what is this new right heart failure definition telling us? And so the study that we're going to spend the rest of the time talking about is this one. And so this was from patients that were implanted from 2014 through 2017. So it's about 8,000 patients. If you look at the patients who had continuous flow devices, there's about 7,500 patients. And we wanted to look at patients at 3 months because we wanted to have a special look at what we thought was quote unquote late right heart failure. So beyond 3 months. And again, we can talk in the discussion period about whether that's late or not. But when you look at the patients who are alive on device with 3 months of follow-up, we basically group people into that time period as having no right heart failure, mild right heart failure, or moderate to severe right heart failure, and then follow them over time over the course of 12 months of support to see sort of not only what the impact of right heart failure at 3 months would be, but what the change in right heart failure would look like over time. So if you had no right heart failure, were you likely to get it later on? If you had a lot of right heart failure early on, does that mean you stay that way? So this was the STS Intermax definition of right heart failure. Basically, you had to either have documentation of elevated central venous pressure by the things there. I won't go through them, I won't read through them all, or you had to have some sort of manifestations of elevated central venous pressures. And so when we were trying to sort of figure out who to include, we said, well, it could be one of these things or the other one, but we decided to include just patients with both of them to make it a little bit more likely that that person truly had right heart failure. Now you can say, well, I can think of things that would give you elevated CVP and manifestations of elevated CVP that maybe aren't necessarily right heart failure. And I don't disagree with you. But that's kind of the way, kind of what we're stuck with the definitions. And maybe we can talk a little bit about that in the discussion period. So you had to have both documentation of elevated central venous pressures and some sort of manifestation of those as well as documented in the database when patients come back to clinic. The other thing to keep in mind with this is that we knew with the introduction of this more complex definition of right heart failure, it would be more of a burden on those who are entering data into the Intermax database, which is typically the VAD coordinators. And they're already sort of overworked and overstretched as it is. So we wanted to try and make this a little bit easier. And the way we decided to make it a little bit easier is the way we coded the timing of right heart failure. So we thought it would be pretty impossible for people to go back and say, okay, on June 3rd of 2021, you met these criteria. I just don't think we would ever really get those dates. So we basically looked at time points, and that's the way we should interpret the data for the rest of the study when you're looking at the evolution of right heart failure over time. So as the slide here shows, that at some point at the beginning of the time period, say 3 months, and the time point ends at 6 months. And so if you can say, okay, at 6 months, did you have right heart failure? Basically, it's looking back in time. Did you meet these criteria, which you can see this little table inset at whatever time X? We're not documenting that time X, but if you met the criteria for right heart failure between 3 months and 6 months, at 6 months, you would say you would be categorized as having had right heart failure. And then we would categorize the severity of the right heart failure. So it didn't matter if it happened here or if the right heart failure happened here, as long as it happened before you got to 6 months, but after 3 months, which was the time period before, then you were counted as having right heart failure at whatever degree at 6 months. And even if you had a couple of episodes of right heart failure, you were just coded as having whatever the more severe episode of right heart failure was at that time point ending. So again, whether it's between 3 and 6 months or whether it's between 6 months and 12 months, if it happened between those two time periods, that right heart failure episode was attributed to the end of the time period that you're looking at. I won't spend much time on sort of the patient characteristics. So these are just sort of what the patients look like at 3 months overall and by categories of right heart failure: no right heart failure, mild right heart failure, or moderate right heart failure. As you can see that for the most part that there were differences between the groups. Typically, the folks with more severe degrees of right heart failure had more severe manifestations of elevated right-sided filling pressures or pulmonary hypertension, or more commonly had right ventricular dysfunction or had low sodiums or high creatinines. And it wasn't dramatic differences between the two, but they're statistically significant. But I think we would all recognize that patients who had previous right heart failure, by the time you get to 3 months, that their baseline characteristics are going to look a little different. So just looking at prevalence of right heart failure over time, this is the only time where we included severe right heart failure, which is by the definition of this study was needing an RVAD, because the reviewers said, well, you said it wasn't very common. Can you prove to us it wasn't very common? And the reality is if you get to beyond 1 month, the incidence of subsequent RVADs thereafter are really, really low. So we're mostly looking at people who either require admission for diuresis or require admission for inotrops and diuresis and pump adjustment. There's very, very few late right heart failures that require right ventricular support, or maybe or at least that we're hesitant to put in right ventricular support late. Some of them may require it, but we just don't put it in. So what did things look like in terms of just mortality? So again, all of these patients survived to 3 months. And then at 3 months, they were categorized as, did they have right heart failure between 1 month and 3 months? Because that's the interval, that was the sort of interval looked at before 3 months to determine whether or not you had right heart failure at 3 months. And you can see that if you had no right heart failure, which is in green, mild right heart failure, which is in blue, or moderate to severe right heart failure, which is in the orangish color, the patients who did not have right heart failure had a much lower cumulative mortality over the subsequent 9 months, so getting out to a year, than either of the right heart failure groups. And not surprisingly, the mild right heart failure did better than the moderate right heart failure. When you look at sort of total patients at risk, most of the patients in the study didn't have right heart failure between 1 month and 3 months. So it's about 5,500 patients. And only about 300 patients in the mild and moderate to severe. So even when you're kind of looking at this big group of patients between 1 month and 3 months, when you're looking at the incidence of occurrence of right heart failure as defined by the study, it wasn't super common. Then the question sort of becomes, well, if patients are still alive, what do the competing risks look like? I think you're all used to sort of seeing competing risk analysis, and that's these two curves, A and B. And so instead of looking at no right heart failure and looking at the competing risks, we just did the individual competing risks to say, maybe the patients who had moderate right heart failure were transplanted more often, or maybe the patients who had no right heart failure were transplanted more often. And so if you look in panel A, which is on the left, the patients are all surviving to 3 months. And when you look at mild, moderate, and no right heart failure, the same colors as the prior slide, you can really see that the incidence of death was higher in the group with moderate right heart failure, and the incidence of death was much lower in the patients with no right heart failure. But when you look at B and the incidence of transplant, then we see the same thing with the incidence of just pumps, either pump being explanted or turned off for whatever other reason. We didn't include this in the study because the numbers were really low. So the patients were doing poorly with right heart failure at 3 months because they were dying, not because of a difference in transplant. When you look at the transplant rates between those three groups, that really wasn't significantly different over time. So the patients who had worse degrees of right heart failure were doing worse at 12 months because they were dying. What other things do we look at? So we try to look at GFR over time. There was much more of this data than some of the other data I'll show you over the course of the next couple of slides. The patients who had no right heart dysfunction at 3 months tended to have better renal function, and they tended to maintain better renal function over time than the groups who had right heart failure, which isn't a surprise, but it's nice to see documentation of that at least over the first year. And we understand that there's a lot of other things that contribute to renal function, not just right heart failure. So there's other things going on here, but in general, patients whose right hearts work tend to have better renal function. When we looked at other things like quality of life, which is on the left by a visual analog scale and 6-minute walk test, we saw the same sorts of trends over time. The caveat being that these data had a lot of missingness. So they're particularly the 6-minute walk distance. When you looked at the visual analog scale, at 3 months, the patients with no right heart failure tended to have slightly better quality of life, but interestingly, kind of over time, despite the survival not being as good, and adverse events being higher, which I'll show you in a couple of slides, there really wasn't a difference in quality of life. Now, I don't know if this was because there wasn't really any difference in quality of life because we're using the wrong measures to assess quality of life, or this all has to do with the missingness of the data for the quality of life. It probably is maybe some contribution of all those things. And the same thing with the 6-minute walk. In general, patients who had no right heart failure tended to have a better 6-minute walk at baseline, so at 3 months. And when you follow them over time, their exercise capacity tended to be better, at least as measured by 6-minute walk, than the patients who had some degree of right heart failure at 3 months. Again, just to kind of emphasize, the categories you're put in at 3 months, these are sort of just assuming you stay in those categories. It's sort of irrespective of whether you developed right heart failure later or not. And I'll get to sort of what that change looks like over time, if any, near the end of the presentation. So what about other adverse events? And this will be the next several slides. So, I think all of us thought that there would be a difference in some of the major adverse events for patients with right heart failure. Not necessarily because there is a causal relationship, although sometimes there's a causal relationship, but maybe just kind of with all the associated morbidities of being in the hospital and interventions associated with some of these other adverse events as well. But be that as it may, when you look at the incidence of rehospitalization, it's higher in patients who have right heart failure at 3 months compared to the patients who did, not dramatically so, but there's still a difference. And maybe there's not a huge difference between mild and moderate right heart failure. We also looked at the incidence of second rehospitalization, just to kind of get at, well, maybe someone comes in for something that's relatively minor, but they require hospital. So let's look at second rehospitalization just to see if that sort of same trend holds. And it does. I think the degree of difference was about the same. And the difference between those with none and those with some right heart failure is there. And the patients who had degrees of difference in right heart failure weren't all that different, similar to the first hospitalization. What other things? So GI bleeding. So the upper left is the incidence of first GI bleeding, and the bottom right is incidence of second GI bleeding. Clearly, the incidence of first GI bleeding is lower in patients with no right heart failure at 3 months. There's less of a difference, but still a statistically significant difference for the incidence of second GI bleeding, which again kind of gets into this, how much of this is because of the right heart failure and how much is because of other things and other adjustments and other comorbidities that go along with right heart failure. Other major adverse events. So if you look at stroke, there's a significant difference, not as dramatic as something like GI bleeds or rehospitalizations, but the group with the lowest incidence of stroke was in patients who had no right heart failure. And as you recall from the very beginning of this, there were very few, if any, HeartMate 3s in this group of patients. Actually, I think there were no HeartMate 3s. So this is still a group of patients who are predominantly HeartMate 2s and HVADs. When you look at something like pump thrombosis, which we tend to sort of associate with the HeartMate 2, or at least higher incidence in the HeartMate 2, there didn't seem to be a big impact on right heart failure status at 3 months on the subsequent development of pump thrombosis between 3 months and 12 months. And then lastly, if you look at something like VAD-associated infections and non-VAD-associated infections, those who had no right heart failure or lower degrees of right heart failure tended to have fewer cumulative incidents of infection over time, whether it's sort of infection in general or VAD-specific infection. So the last couple slides I would just want to show you are they're Sankey diagrams, and we chose to use these because we thought it kind of best represented what happens with patients over time. So let me talk you through these next few slides. So if you look at this panel, so this is a group of patients who had no right heart failure at 3 months. So again, between 1 month and 3 months, they had no episodes of right heart failure. So they are categorized at 3 months as having no right heart failure. And then what happened when you looked at them at their 6-month follow-up, and what happened when you looked at them at their 12-month follow-up. So of the sort of 5,500 patients that had no right heart failure at 3 months, when you looked at them at 6 months, about 2/3 of them, or slightly less than 2/3 of them, had no episode of right heart failure between 3 and 6 months. Whereas a small handful of patients, 2.5%, developed mild right heart failure, and 0.9% developed moderate right heart failure. Some of the other people were sort of lost to the follow-up, either because they died or because they got transplanted or some other reason, or they didn't have their forms filled out. So there's a handful of those patients as well. But in general, if you don't have right heart failure at your 3-month visit, so again, you had no episodes of right heart failure between 1 month and 3 months. So we categorized you as no right heart failure at 3 months. At 6 months, most of those patients continued to not have right heart failure. But it wasn't like it was impossible for patients to develop late right heart failure. It just wasn't super common. And the same thing when you go from 6 months to 12 months, if you look at the patients who had no right heart failure at 6 months, about a little over 2/3 of those patients didn't have right heart failure at 12 months. And a small group of patients developed an episode of mild or moderate right heart failure. So while those who have no right heart failure at 3 months have lower incidence of death and some of the major adverse events and tend to have better renal function, and there's some signs that they have better functional capacity, it doesn't mean that there's 0 incidence of right heart failure beyond that time. It still can happen. It's just not super common, but it's reasonably common and something that we need to keep an eye on. So compare that to the patients who were categorized as mild right heart failure or moderate right heart failure. So on the left in panel B is the patients who were categorized as mild right heart failure at 3 months. And on the right in panel C is the patients who were categorized as moderate right heart failure at 3 months. So let's go back to panel B real quickly. So if you look at the 300 some patients that had mild right heart failure between 1 month and 3 months, so they were categorized as having mild right heart failure at 3 months. Interestingly, about half of them at 6 months didn't have another episode of right heart failure. About a quarter of them had another episode of mild right heart failure. And you can see, a dozen or so percent of them went on to have, I take that back, about 4% of them went on to have moderate right heart failure. And then there was a group of patients who either died or got transplanted or were lost to follow-up for some other reason. So despite having mild right heart failure at 3 months, there's a big bulk of those patients won't have another episode of right heart failure at 6 months. And of those patients who didn't have another episode of right heart failure at 6 months, about half of them continue to not have an episode of right heart failure at 12 months. So just because you had sort of an early-ish right heart failure between 1 and 3 months, that doesn't necessarily doom you to having right heart failure for the rest of the time you're on support over the course of the first 12 months of support. That being said, the incidence of mild and moderate right heart failure still is much more common in this group of patients than the group of patients who didn't have right heart failure at 3 months. And you can see some of the patients who had mild right heart failure at 3 months and then still had mild right heart failure at 6 months. Some of them went on to not have right heart failure at 12 months. Some of them went on to have another episode of mild right heart failure. Some of them went on to having a moderate episode of right heart failure. So there is a little bit of change over time. And the worse your right heart failure status is at 3 months, the more likely it is to recur in the first 12 months. And then lastly, in the 300 odd patients or 296 patients who had moderate right heart failure at 3 months, which is panel C, you can see it's somewhat different. About a third of the patients had no right heart failure by 6 months. About 7% of them had an episode of mild right heart failure. And about a quarter of them had another episode of moderate right heart failure. So clearly the patients with higher degrees of right heart failure between 1 and 3 months are at higher risk over time for having subsequent episodes of moderate right heart failure. So there is some trends over time that when you get to around 3 months, you start to kind of call the population out into sort of a high risk group, a medium risk group, and a low risk group. And those who had higher degrees of right heart failure early on tend to have higher degrees of right heart failure later on. Those that had no right heart failure early on tend not to get it, but it still can occur late, even in patients who didn't have early right heart failure. So I thought maybe I'd just sort of stop there. I have some sort of other thoughts, but maybe I'll just kind of turn it back to the group and chat. I know that I kind of went through a lot in a relatively short period of time. And so maybe I kind of throw it back to the group to answer any questions and maybe talk a little bit more about the implications of some of the findings.
Thank you so much. I mean, that was a wonderful talk, and I'm sure we have a lot of interested people who have some things I'd like to ask you. It looks like Dr. Balamkonda has her hand up, so I'll let Lavi talk first.
Hi, Jeff. Thank you so much for coming and giving that excellent talk. A couple of questions. I mean, do we have a sense based off of the baseline echo or clinical parameters, and then immediately post-op prior to discharge clinical parameters as to there's a correlation between RV function and development of right heart failure at 3 months?
So there is some, and I think that's been reported in prior series when looking at sort of risk factors with Intermax. The problem with Intermax is it doesn't really have a lot of great markers so we have the hemodynamics, and most people have hemodynamics, but they're hemodynamics on unknown levels of support, right? So, just because someone has a right atrial pressure of 7, it might be someone with a right atrial pressure of 7 and walked in from home and is going to get their pump the next day and their right ventricle is very good. It could, at the same time, could be someone who has a right atrial pressure of 7 because they're on a balloon pump and they're on lots of dobutamine and maybe some dopamine, and they've been in the hospital for 3 weeks, and they go get their, that's their last set of hemodynamics before they go get their VAD. So even some of those criteria, even though some of those criteria are a little bit hard to interpret. And then from an echocardiographic standpoint, there's not a lot of great data. I mean, we have the degree of TR as reported by the centers, the RV function, and that's just sort of a subjective, mild, moderate to severe. But we don't have a lot of the kind of more complex tissue Doppler and other techniques that people have looked at to better quantify, or at least augment our ability to quantify right ventricular dysfunction. So I think Intermax, although we can learn a lot from Intermax, I think the kind of gory details and the more granular look at risk factors, I think just aren't there in Intermax, unfortunately, to really say. And we try, and as part of this analysis, we just tried to stay away from that, the sort of prediction question. We just said, okay, you got your continuous flow VAD, you made it to 3 months. How are you at 3 months? How are you between 1 and 3 months? What was your right heart failure status? And then try to sort of look at later episodes of right heart failure to kind of better characterize what was the impact of later right heart failure, but also what was the sort of subsequent tempo of its development.
Yeah, thank you. And it completely makes sense. And I guess the intention of that question really is, as a clinician, you're wondering why suddenly someone's developing a right heart failure at 3 months or 6 months or 12 months or whatever the time frame is, right? So, and again, like you alluded to in the talk, there's so many things that go into causing right heart failure. It could be the pump speed that's too fast, and now the RV looks like it's worse, and the JVP is up. It could be pump failure. It could be thrombosis in the pump, and it's got nothing to do with the RV. It's just about, and especially with the way we are defining right heart failure, which is elevation of JVP and edema. So that's why I was asking to see if there's something wrong with the RV to begin with, and if it's truly right heart failure that we're detecting or calling.
I mean, I suspect that it is, because I think a lot of those other things, are relatively rare. Particularly things like pump thrombosis. But I mean, who knows how people are managing the pumps? My sort of only take from the hemodynamic data that's out there, and a lot of this came from when NEAR was in Chicago, was that if anything, it's not so much the pump speeds are too fast as people's pump speeds are too slow. So it's not like your pump speeds are so fast and you're quote unquote sucking the septum over and inducing right ventricular dysfunction. It's more that you're inadequately decompressing the left ventricle and maybe sort of leaving a state of kind of persistently elevated afterload to the right ventricle more than anything else. But you're right. I mean, we don't really know. The definition is a little bit soft. And like I said, I think you can come up with lots of scenarios why someone may have elevations and manifestations of elevated CVP that aren't necessarily really a primary pathology of the right ventricle, but it's kind of what we have, right? I mean, it's the only way to kind of look at the data, because that's just the definitions that were come up with, that were developed at the time.
Yeah, I mean, all the limitations.
Baseline characteristics. The patients who didn't have right heart failure tended to have less right ventricular dysfunction, and they tended to have a lower right atrial pressure, and they tended to have better creatinine. So I think there is some circumstantial evidence that their right ventricles are probably healthier, with the understanding that there's a lot of other factors that are involved too.
And last question before I let you go, what do you think, what would you speculate as the etiology of the increased risk of stroke that you have quoted in your central figure? The stroke risk is significantly higher in this RV failure patients.
Yeah, I think that Some of it may be pump management. Some of it may be anticoagulation. We didn't parse out hemorrhagic versus thrombotic stroke. So how much of it's sort of liver congested and, the person's a little bit more bleedy than someone who doesn't have liver congestion. How much of it is other factors with, lower pump speeds because you're worried about the RV. And so you don't get as much washing, and then maybe the valve doesn't open up as much, and you're a little bit more likely to get a stroke. How much is it you have right ventricular failure, and just in general, you're not in as good of a shape, and the balance between thrombosis and bleeding isn't as finely tuned as someone who's in much better shape and doesn't really have residual heart failure. It could be all those things. The inflammatory state may be better in someone who doesn't have right heart failure than someone who has persistent low degrees of right heart failure, and so they may be at higher risk of stroke. Not sure.
Thank you so much.
Jeff, this is Tarek. Thank you so much for an outstanding talk. This is really close to our heart because we think about it. And so, couple questions. So, a lot of people come up with, ways to predict who's going to have RV failure. The bottom line is a lot of these patients are going to need an LVAD because they don't have any other option. And we're dealing with people with biventricular failure. So in your kind of, synthesizing all the information out there and writing the paper, how do you minimize the risk of RV failure in someone who's going to go through with an LVAD, to quote unquote, the surgeons will tell us, like, let's optimize this patient before. So what do you think should be done kind of before, and then obviously intra-op, and then afterwards to reduce this risk of RV failure?
Well, I wish I knew. I don't have a great answer, but I think you're right. I mean, I think that the preoperatively, it's better to go into the operation with decongested kidneys and decongested liver and a decongested lung and just sort of better right heart hemodynamics. At the same time, I think I think 10 years ago, I would have probably spent another several days monkeying around to see if I could make the person's hemodynamics look better. I think I'm less likely to do that now. It is what it is. The risk is what it is. Just take them to the operating room, because lots of bad things can happen as you kind of wait for the right heart numbers to look better, particularly as you're escalating support. Because like I said earlier, I don't know what it means to have okay-ish right heart hemodynamics on tons and tons of support versus someone who's on less support versus someone who's on no support. Although I suspect that right atrial pressure of whatever value you're shooting for probably is less meaningful on someone who's on tons of support versus someone who's on no support whatsoever. I think intraoperatively, I defer to some of my surgical colleagues in terms of the sort of, tricks of the trade, but, the kind of get in, get out I think there's something to be said for that, because I think the longer the bypass times and the more you get into bleeding, the more stuff you run into. I think the bigger the problem in monitoring folks' PA pressures and right atrial pressures to make sure you're optimizing their volume status and they're not coming out with really high right atrial pressures, I think are all really important. And I think the same thing kind of goes in the early perioperative management as well, in terms of just making sure you're getting adequate volume off and you're supporting the right ventricle. You don't have to run the pump super high. I think we all know that now. But I think it's just sort of the small things. But even amongst all that, so when you look at sort of all these early predictive things for RV failure, is it really a bad thing? Let's say someone's at high risk for RV failure, defined as the need for an RVAD or 14 days of inotropes, and they don't really need an RVAD, and it takes you 22 days to get rid of their milrinone. But then you get them home and they do okay. That person has RV failure, and you've predicted that they have RV failure, but so what? They did okay. And maybe by month 3, they're in that no recurrent right heart failure group. So I still don't think we really actually know. I'm not even sure how useful some of these things are. I would like to know the people that are going to have such bad right ventricular dysfunction that they're going to need an RVAD. I think that's important. But do we really care about the prediction of prolonged inotropes? I would say, well, in the person that never comes off inotropes, yes, that's important. And I don't disagree with you, but, is there really something bad about that? I mean, some of that early Intermax data would suggest that the longer you're on inotropes, the more likely it is to put after the operation, the more likely it is you have or to have a worse outcome. But, some of that is center preference and center styles. And I'm just not sure exactly what it is ultimately we're predicting. And, particularly for someone who's a bridge to transplant, maybe if they get an early RVAD, they do okay and you explant it and their hospitalization is longer and it costs a little bit more, but maybe they do okay in the long term. And is that necessarily a bad outcome? No, not necessarily. So the sort of prediction of right ventricular dysfunction, I think we're still hampered a little bit by the sort of what it is that we're predicting. If we knew that we were predicting people who struggled long-term, those patients maybe with moderate right heart failure at 3 months, that although some of them do okay over time, many of them don't. I think that's a little bit different of a predictor than the sort of early markers that we're currently trying to predict.
I mean, I completely agree with you. And a lot of times, we end up, the treatment ends up being worse than the cure because we're trying to optimize those right atrial pressures and hemodynamics. And there, some people even believe in putting a balloon pump before. And I personally think, the inotropes might make the numbers look better, but I don't know how good it is to be flogging the heart for that long before doing something. And then the other thing is like the post-operative management seems to be kind of all over the place as well. Some people might respond by saying, okay, there's high risk for RV failure, so just let's put in an RV support device early. And some people will write it out. I don't even know what the right answer is. And I don't know if you have experience with that. I've been getting texts from the surgeons right now because we've got, several patients like waiting for LVADs with RV failure to start off with. And they're like, well, what should we do, before and after to prep for this kind of high risk? And I don't know what the right answer is, should we just do a Protect Duo prophylactically? Like, should we just try to aggressively diurese afterwards, or just do high dose inotropes and, inhaled nitric oxide? It just seems like a little bit that everyone's got a different answer that they feel very strongly about.
Yeah, I think there's a lot of home cooking, and I think that's that way because there's just not a lot of evidence. It's my sort of chicken soup analogy that I think everybody has their own sort of recipes for chicken soup, and you think yours tastes better than everybody else's, and the ingredients are basically the same everywhere, except you have your little secret right heart failure ingredient, and other places have their secret right heart failure ingredient. But in the end, it is what it is, and so. I try not to, I guess I try not to discount what can happen in the operating room in that, like I said earlier, I think you can take someone whose RV looks marginal and has criteria which would mark it as marginal, and they can do very well in the operating room and not have any problem at all. And so rather than say, okay, this person doesn't look, their right ventricle doesn't look good and they're higher risk for RV failure and saying, oh, we're just going to preemptively put some sort of temporary right ventricular mechanical support in them. I don't know. I don't know that's needed. I think you have to sort of let the ORF play itself out. And, conversely, someone who doesn't look like they have a bad right ventricle, but, bad things happen in the operating room. It's not like you should rest on the fact that, oh, the person's RV was normal going in, so I'm not going to worry about their right ventricle now. I'm not suggesting that people wouldn't worry about it, but it's more just sort of kind of, I think if someone's at high risk, being a little bit maybe more meticulous and being a little bit more careful, but that's not always doesn't mean something bad is not going to happen. And I guess the biggest thing is if it looks like the person's struggling to get out of the operating room, I'd much rather have them come out with an RVAD than rocket fuel, because 48 hours later, their kidneys don't work and their liver doesn't work and they're vasoplegic, and then that sort of die is cast, and it's hard to get those people back.
Thanks so much, Jeff. That's really actually very helpful, because it's.
I feel like it's very unsatisfying, because we have the same conversations amongst all of us, and I think it's just, I try not to get too fixated on kind of moderate amounts of right ventricular dysfunction. it's kind of one of those things you sort of overall look at the person, look at what you're trying to accomplish. Are they DT? Are they BTT? Although fewer and fewer people were BTT. What's the rest of their organs look like? Are their kidneys marginal and they're not going to tolerate much of an RV insult, or do they have a robust kidney reserve and they could tolerate a little bit of RV insult? Are they a multiple time re-op? Are they going to need a lot of rehab? And try and kind of put it all together into sort of assessment of risk, and then go for it and recognize that the person's RV doesn't work very well, and try and be as meticulous as you can in your care afterwards.
Great.
Maybe I can ask you guys a question. So are there things that you guys do? Are there techniques, styles, approaches, either in the operating room, beforehand, afterwards, for patients who you have concerns about right ventricular dysfunction? I'm always curious what other people are doing, because like I said, I fully admit that I don't have all the answers.
We drive the CCU nursing staff crazy because every attending has a different way of doing it. Our surgeons blame us for not optimizing the patient enough prior to surgery. I don't know if you guys have anything to add.
I mean, I think one of the things that I think both in Pittsburgh and here, I think we've maintained pretty open lines of communication for people who are sort of marginal, and to not get kind of caught up in the one more day thing. And, I talk, we try to talk with the surgeons when we think that the person's going every day, and say, here's what we did over the last 24 hours. Is this person any better or not? And should we just take them to the OR now? And the surgeons say, well, give them one more day, or try and get a little bit more volume off. And then, the next day you say, I tried and nothing worked. And then I think everybody kind of knows what they're getting when they roll into the operating room.
Arnold, Patrick, Mohammed, you guys are the men in the arena. What do you guys think?
Sorry, Tarek. Very interesting talk. It's challenging. I know, it's how exactly how to manage some of the stuff, and I think it's very. We try to manage these people together and discuss it, but I think it's a very thoughtful discussion. I don't have any specific comments. How do it's because I think you have to go by case basis here. But a great talk.
I think that it's. I think we all expected we would see late right heart failure, and again, we can argue about sort of what it means to be late right heart failure and what time frames and how severe. But it was still surprising that there's 1 out of 10 patients who don't have right heart failure at 3 months get it some other time in the first 12 months, or the remainder of their 9 months on support over the first year. So it can still happen. The question is sort of, why is it happening in those patients? Is it our fault because of inadequate diuresis, because of improper pump management, or is it just because of sort of the progression of the pathology of the right ventricle, or some combination of all those sorts of things? And I think it was also a little sobering to see that at 3 months, if you were categorized as having more moderate degrees of right heart failure, it recurred a lot and had a really big impact on adverse events. And so the question is, who are these people that have moderate degrees of right heart failure at 3 months? The good news is, when you looked at the total number of patients that were implanted, not that many people were categorized that way. Of the 6,000 odd patients, about 300 of them were. So, I think you could be sort of a glass half full and say, hey, that's a lot of patients who survived the 3 months who don't end up having more than mild right heart failure, and they tend to do okay over time. The glass half empty is that, boy, even people who do really well at 3 months can still develop mild or moderate right heart failure in the next 9 months. And that could probably impact their incidence of other adverse events. So I think you can look at it both ways, but I think it was sobering that the patients who had moderate degrees of right heart failure did so much worse.
Yeah,
and I think we all sort of recognize
also,
that, but it's nice to have some numbers to put to it.
It's interesting also, sometimes you do cases that You expect a bad right heart failure, they do fine. And, why is that sometimes? I mean, another very interesting, teenagers, we've done 2 or 3 teenagers with LVAD. One, actually, we were convinced we needed RVAD, no problems. And they tend not to require, and recover. I mean, obviously a different pathology, but still, why would that be so different than the adults?
Yeah, I mean, it's it's sort of, why do they have right heart failure, right? Does someone have right heart failure because they have really bad MR and elevated PA pressures and really bad afterload, and when you totally unload them, they do really well? Or do they have RV failure because they just have some sort of really advanced right ventricular myopathy, and it doesn't matter how much you unload them, the right ventricles just don't work? And I don't think we can parse out those phenotypes either. So after, 10 or 15 years of looking at this and doing this, I feel like I don't know a whole lot more than I did when I first started. We have some data to sort of characterize the incidence of these things, but I think we all still struggle to risk stratify. But sometimes I feel like we get a little bit too caught up in predicting something rather than just sort of putting in kind of the calculator of how much overall badness will this person have, and making a more holistic decision and not being super hyper focused on the person's right ventricle.
Yeah.
So I know we're coming to the top of the hour, so I don't know if anybody has any last questions for Dr. Teuteberg.
Actually, Jeff, I have one kind of logistic question. And
Sure.
being involved in ISHLT and stuff, but, we got a hold of the Intermax data from BioLink, but it stopped in 2017, and there's a lot to be said about being able to have access to, the HeartMate-3 data, the most recent data. Do you think that the the ISHLT, or maybe these these groups would be interested in helping that data be available like it was, so that we can gain insight from it, because it's now close to impossible to get access to it again, which is kind of unfortunate, because I think the papers were adding a lot to our management decision making.
Yeah, no, I don't disagree. There was a lot of, I spent a lot of my sort of president-elect and presidency of the ISHLT kind of dealing with the migration of Intermax from the NHLBI to the STS. And it's not as if the ISHLT didn't have interest in, taking over, quote unquote, the Intermax database. NHLBI, I think, wanted to see the database survive and be used in a way that could help payers and centers and patients kind of understand the sort of lay of the land. And they felt that STS was better positioned because of the database that they had, even though their databases typically went to 30-day outcomes, that they had the sort of already the existing infrastructure to be able to better support that. And so ultimately, that's why they chose the STS. Matter of fact, I think they just mostly went to the STS, and we weren't even sort of given the right of first refusal. So there's a very complex political issue, and sort of, and I'm not blaming the NHLBI. I think that there are good reasons for it to go to the STS too. But that being said, I think that the sort of closer working relationship that the ISHLT used to have with those who are running Intermax, although it still exists in sort of a collegial fashion, you have to go, like you said, you have to go through the STS. I think in the near future, I think there's very little chance that there will be open access to the STS Intermax database. It's kind of part of their business model, and it's not that they're purely making money off of it, but it's a resource to them, and they pay a lot to maintain it and to improve it. And so, I think that in its current iteration, there won't be open access. I mean, there is access to it in terms of how you apply, but it costs money. the other thing that we have sort of floating around in the background is that the STS has involved heart failure cardiologists and their STS working group. I have the fortunate opportunity to kind of be part of that. There's also an RV task force that's part of Intermax that we have the ability to ask for data and do research studies, and this is one of the studies that kind of came out of that working group, so that we can hopefully respond to the community's interest and don't have to wait for people to apply to get data for specific research interests. We can kind of keep pushing the RV issue and publish data and try to meet the community's needs and understand the community's needs and do research studies that reflect those needs. So it's kind of a long-winded way of saying, I don't think that there'll be an opportunity to have open access to the STS Intermax database anytime soon, but I hope that there are methods out there to respond to the community's needs for more information. So it is what it is for the time being, I think.
Thank you so much. I mean, really appreciate you're trying to get us, global access, but absolutely. So if anyone else has any, this was really, really, really helpful. I mean, we've been talking about this every day this last week, so.
All right, well, like I said, I really appreciate you guys inviting me to chat with you today. If you have any questions, please feel free to reach out anytime. Email me, call me. I'm happy to chat offline anytime.
Thank you, Jeff.
Jeff, before you leave, I just had one quick question for you.
Sure.
What's happened to the mix between LVADs and transplants at Stanford for the last week? You guys, what's the kind of ratio now for your practice?
Yeah, we're essentially doing 0 bridge to transplant VADs.
Okay.
It's almost every VAD now is DT, and our numbers of our VAD numbers are picking back up, but they were cut at over half.
Okay.
So I mean, we did sort of 30 VADs last year and over 100 hearts. So our heart numbers keep going up, and our VAD numbers took a huge hit around the allocations time. For good reasons, we could get people transplanted really quickly, but essentially everybody is DT now.
Thank you so much. This is really helpful. Thank you very much. Hope everything's well with you.
Thanks, guys. Appreciate it. Have a good one.
Take care.